Welcome to session 4 of the Public Health Surveillance course. In this session, we'll cover vital registration and vital statistics. The session's really about how we track vital events, such as births and deaths, and the related information that goes along with those events. And we'll also go through some examples of the kinds of statistics and metrics that get generated from vital registries for the purposes of public health surveillance. But before we jump into the lecture, this is just an early reminder that your first reaction paper is going to be due on October 1st, and the topic is going to be surveillance for behaviors and risk factors. And that's the topic for next week's session, by the way. So just revisiting the general guidance on the reaction papers here, it's important to think of these readings for the reaction paper as a group of readings that have related themes. So as we've mentioned before, we're not looking for independent standalone summaries of each reading. Rather, we're looking for your thoughts about some of the themes that you see across the different readings and how they may be interrelated and how they may contradict each other if that's the case. So treat the given week's reading as an integrated whole when you write your paper rather than a series of unrelated articles. Also, we grade these reaction papers in a blinded fashion to help ensure objectivity and fairness, and this requires that you submit everything via the assignment links on Blackboard. So importantly, in your actual documents that you submit, don't include any identifying information on your submissions like your name or student ID number or anything like that. This way, Blackboard will keep track of everything submitted without us being able to see identifying information while we're grading. So there's a lot more guidance on the reaction papers in the syllabus, and I urge you to consult it before you begin the process of writing your first reaction paper. So in this session, we'll be focused on vital event monitoring for vital statistics, and we will be covering two broad categories. The first is when vital registration, that is birth and death registration, is complete and cause of death information is relatively accurate. This is the model for resource-rich settings, and we'll use the examples of New York City and the United States. And the other category is when vital registration is non-existent or very incomplete, and the majority of births and deaths are not registered, for example, because they tend to occur outside the health system, for example, at home. And then we'll go on to discuss briefly how the global burden of disease statistics take these two different scenarios into account when generating estimates of the global number of deaths and the global rankings of the causes of death. So just to remind you where this fits in, vital registration, like notifiable diseases and events, is one of the major sources of information for public health surveillance. Next week, we'll cover surveys, and the week after that, we'll cover administrative data as sources of information for public health surveillance. So vital registration refers to the recording or documenting of the occurrence of vital events, such as births and deaths, and associated information that goes along with those events, in a vital registry specifically. Vital refers to, of course, necessary things for life or very important. So that vital registration you can think of as the registration of these fundamental important events that represent the start and the end of life. As we alluded to in the first session on the United States, vital registration is not nationally coordinated. Birth and death certificates are state or jurisdiction specific and therefore decentralized, and the process is voluntary, similar to notifiable diseases and conditions. There are officially 57 vital registration jurisdictions in the US, and that includes all 50 states, but also some special vital registration jurisdictions. The other 7 jurisdictions in the U.S. include New York City, the District of Columbia, and 5 U.S. territories listed here. In each of these 57 settings, there are separate vital registration systems that capture information on all births and deaths. So let's zoom in on New York City, which is an official jurisdiction for vital registration here in the U.S., starting with birth registration. All pregnancy outcomes, whether the pregnancy results in live birth or if there's a spontaneous or induced termination of pregnancy, are required by law to be reported to the New York City Health Department or New York City Department of Health and Mental Hygiene. This reporting is accomplished through the use of birth certificates or certificates of spontaneous termination of pregnancy and certificates of induced termination of pregnancy. These are the forms or the source documents that contain information about the occurrence of vital events and the information surrounding them. On this slide and the next one, you'll see what a birth certificate looks like in New York City, which can give you a sense of the kinds of information that's captured. This is the first page of a certificate of birth, and you can see it captures information for a single child. Of course, there can be multiple children per birth, and this means that there would be more than one birth certificate for each child, or there would be one birth certificate for each child. However, in addition to the child-specific information on each birth certificate, there's also a place to capture information on pregnancies that result in multiple births, including the number of babies delivered and the birth order of each child. And there's also a place for information about the newborn's parents, as well as a place for a provider to certify that the birth actually took place. So this first page of the birth certificate is called the public part of the birth certificate, which means that it's available to certain individuals for certain purposes, like to the immediate family or for identity verification purposes. And the last two pages of the birth certificate are the so-called confidential components of the birth certificate and include more sensitive information, including medical information about the parents, as well as prenatal history and information about the prenatal care for the pregnancy, some clinical outcomes, information about financial information or insurance coverage, and also factors related to maternal morbidity in the mother. Also, to access the information on the confidential section of the birth certificate is even more restricted compared with the public section, and it's usually limited to the government agency that administers birth registration, in this case the New York City Health Department, but it may also be made available for medical purposes or for legal reasons, such as in criminal cases. And on the last page, there's information about the labor and delivery, such as the nature of the labor, whether or not anesthesia was used, the nature of delivery, including things like whether there was a C-section, and that makes it possible to track trends in the methods of delivery, for example. Also, you'll see the birth weight of the infant, the APGAR score, any congenital abnormalities or other abnormal conditions that were present, and information about the delivery of hepatitis B vaccination, which is recommended within 24 hours of birth. So you can begin to appreciate the richness of some of the information that's included on both the public and confidential sections of the birth certificate, and how it could be potentially useful for public health surveillance and monitoring and improving population health outcomes around pregnancy and birth. So here's what some of the statistics show, starting with the birth rate. This is a long view going all the way back to the late 1800s, showing the birth rate per 1,000 population in New York City through 2020. You can get a sense of the trend and how it's declined. A baby boom is represented starting around 1940, as well as a lot of other relevant developments on the timeline here. It ultimately culminates in the estimate of New York City's birth rate for 2020, which is the lowest in history, 11.4 per 1,000 population. Looking at the table of contents of the 2020 Summary of Vital Statistics report for NYC, you can get a sense of the rich statistics that can be generated using information from the birth certificates and other pregnancy outcome certificates. And there are even more tables and figures in the appendix. I'll just highlight a few things from the report. Notably, this table with raw numbers wasn't in the 2020 report, but it was in the 2015 report, and I included here just to give you a sense of the numbers that we're talking about here in terms of births and other pregnancy outcomes. So here you can see in the year 2000 there were about 120,000 live births citywide, 9,800 spontaneous terminations of pregnancies, and about 63,000 induced terminations, which gives an overall estimated number of pregnancies of about 195,000 citywide in 2020. These three pregnancy outcomes are used to determine the overall pregnancy rate. And this at least gives you a sense of the raw numbers and the rates per 1,000 population going alongside here, so you can get a sense of how it varies by age, and we'll see some slides on that in a bit. So back to the 2020 report, since vital registration happens all across the US, there's of course a national birth rate and a trend. And this slide shows New York City's trend in the birth rate since around 2011 compared to that of the US overall. And the first thing you notice is that both of these rates are trending downward over time. But also the birth rate in New York City is a bit higher consistently over this time period than the US rate. But that gap has narrowed quite a bit by 2020. However, also remember that because of COVID-19, 2020 was a very unusual year for New York City especially. So the gap may not remain as narrow going forward. It's also possible, of course, to map the birth rate by New York City neighborhood. And what you can see from the map here is that there's substantial variability in the rate of live births per thousand population by neighborhood. It's very high in some places relative to others. In fact, if you look across the map legend, it ranges from the lowest neighborhood with about 5.2 per thousand population all the way up to 25.1. So about a five-fold difference in the birth rate from the neighborhood with the lowest birth rate to the neighborhood with the highest birth rate. And like many, if not most health outcomes, there's a strong relationship with neighborhood poverty. In this case, neighborhoods with very high poverty rates had the highest birth rates, and there's a gradient such that those with the lowest poverty rates at the neighborhood level also have the lowest birth rates. And this gradient has persisted with time. Comparing the rightmost bars on each side of this graph, you can see that overall there's been a downward trend in the birth rate in all neighborhoods from 2011 to 2020. And as you saw in the previous slides, the birth rate has been trending downward steadily for some time. However, the gradients showing that the strong relationship between neighborhood poverty and live birth rates persists, even though the overall birth rate is declining. In fact, they've calculated the overall relative risks here, comparing the rates of birth in the neighborhoods with very high poverty to the neighborhoods with the lowest levels of poverty. And the relative risk in 2011 was about 4.3. In other words, comparing the highest to the lowest poverty neighborhoods, the birth rate was 4.3 times greater in the highest poverty neighborhood compared to the lowest poverty neighborhood. And in 2020, while the absolute difference narrowed between the lowest and the highest poverty neighborhoods, the relative risk was about 3.8, which isn't much of a change. Low birth weight is a risk factor for bad health outcomes, including infant mortality, and using the information on the birth certificate, it's also possible to track trends in the proportion of live births with low birth weight, defined as less than 2,500 grams at birth. And you can see here, again, from an older report, since it wasn't in the 2020 report, there's substantial racial and ethnic disparities in low birth weight that have persisted for quite some time in New York City. And this slide shows the birth rate by age group. You can see that in 2011, the highest pregnancy rate was among those aged 20 to 39 years. However, by 2020, the highest pregnancy rate was among those 30 to 39 years. And the pregnancy rate has been steadily declining in the 15 to 19 year age group, and at a steeper rate than the citywide pregnancy rate shown here in green. It's also possible to focus in on some specific populations, and this figure shows the birth rate just among teens in New York City compared with that of the US. And focusing on the two middle lines, you can see that the teen birth rate has been consistently higher in the US compared with New York City, but both have declined over time. And for the New York City teens, you can see that this teen birth rate stratified by age, for those teens aged 18 to 19 in pink, and those less than 18 in blue, birth rates were much lower among the younger teens, and their birth rate was reduced by more than a factor of 3 during the last 10 years. So that's progress. This slide shows the trends in the rate of induced termination of pregnancy by age group, and you can see that some of the more rapid declines in induced termination of pregnancy occurred among teenagers. So that trend, compared with the earlier slide showing a substantial decline in the teen birth rates, suggests that there's more success at preventing teen pregnancies citywide. And one of the more fun statistics that comes from birth registration data is the list of most popular baby names in New York City, shown here for 2020. I didn't get the Boss Baby reference. Maybe you do. If so, maybe you can enlighten us on the discussion board for this session. So moving on from births to deaths, the first death records in New York City were filed in 1795, and that was a year when there were about 718 deaths in New York City from yellow fever. In 1803, the continuous filing of death records started in earnest, and these were generated through reports of burials that were happening around New York City. And another key development was in 1805 when the New York City Board of Health was convened and appointed. So how does death registration work in New York City? A physician or medical examiner completes what's called the confidential medical part of the death certificate, and a funeral director completes the section called the personal particulars, which includes things like demographic information. The funeral director then submits the death certificate to the New York City Department of Health's burial desk in order to get the required burial or cremation permits. This filing of the death certificate is required in New York City to occur within 72 hours of death. And filing of death certificates is the primary reason that the New York City Department of Health has an office that's open 24 hours a day, 7 days a week. For the most part, these filings are now completed electronically, more than 93% of the time, but there's still manual filing of death certificates. Finally, there's near 100% complete registration of all New York City deaths. That is to say, it's hard to die in New York City without it becoming known to the medical system and the health department. So here's a blank death certificate, so you can see what it looks like and get a sense of the kinds of information that are captured on the death certificate. There's much less information captured as compared with what we saw on birth certificates in terms of the amount of information surrounding the vital event of death. The top part of the certificate is the medical certificate of death and is filled out by a physician. It includes information like where the death occurred, the time and the date of death, the sex or gender of the decedent, and whether or not there was hospice care. The next part is called the personal particulars section, and it's completed by the funeral director. It includes information like the person's date of birth, their address, their occupation, their original birthplace, and whether they served in the armed forces, their marital status, etc. And the second page is the confidential medical report. It includes some additional information that can be filled out by the funeral director, including information on ancestry and race ethnicity. Below that is where the cause of death information is recorded, and this part is completed by a physician. This information is recorded as a sequence of events or causes which led to the immediate cause of death on the first line of part 1. We'll go into this in more detail soon, but you can see that there's a place for the physician to list the immediate cause of death, and then in subsequent places they can list the conditions or sequence of conditions that resulted in the immediate cause of death. And then there's a place in part 2 to list other significant conditions that contributed to the death. And finally, the bottom of page 2 captures information on whether an autopsy was performed at the time of death, whether the decedent was pregnant at the time, and whether or not there was a potential role of tobacco use contributing to the death of the individual. All of this information is what's used to compile the statistics on the causes of death and the related trends that we've covered in previous lectures. It comes from what's recorded on these death certificates. Of course, from a surveillance point of view, the cause of death information is of great interest in addition to the fact of death. So let's delve into the process of recording the cause of death listed on the death certificate and the process of assigning the underlying cause of death for an individual using the information on parts 1 and parts 2 of the death certificate. The attending physician, or if there's an autopsy, the medical examiner provides information on the causes of death, including the immediate cause or the event that led to the person's demise, followed by the sequence or causal chain of conditions or events that led to that immediate cause. And they can list other contributing causes in part 2. Here's an example of a screenshot from the web-based system that can be used by physicians to submit information on the cause of death. In part 1, the most recent condition and the other causes leading to the most recent condition are termed the literals. And this information taken together is what's used to determine the so-called underlying cause of death. The information in Part 2, while relevant, is generally not used to determine the underlying cause of death. One other thing to note on the right-hand side of the screen here is that there's a place to enter information on the timing of each cause or event. So here's a common example. In this case, the provider listed cardiac tamponade, which is an accumulation of fluid or blood around the heart that prevents it from beating. And this was documented to have occurred 1/2 hour immediately prior to the onset of death. In line B, the provider states that the cardiac tamponade in line A was due to or as a consequence of a ruptured myocardial infarction that occurred about 8 hours prior to that. And they go on in line C to say that the myocardial infarction in line B was due to, as a consequence of, atherosclerotic coronary artery disease that had been going on for about 15 years. And in line D, the provider documents that the atherosclerosis in line C was due to or as a consequence of hypercholesterolemia or high cholesterol that had been going on for 30 years. Lastly, in Part 2, they list heavy smoking as a significant condition that likely contributed to but not resulted in the things listed in the causal sequence of Part 1. Heavy smoking, for example, could have accelerated the timing of death due to the conditions in Part 1. So taking all this information into account, the underlying cause of death in this case would be coded as hypercholesterolemia or high cholesterol. One important note, it may be the case that providers don't always fill out the information in Parts 1 and Part 2 accurately or in a logical order. In this case, it was done correctly. So there's a process of reviewing and formally coding everything that providers lists. And then there's a set of rules that really govern the ultimate coding of the underlying cause of death. At the end of the day, after these rules are applied, the algorithm produces essentially the best guess given what's known about the relationships between the things that providers list on the death certificate. So there's an elaborate coding system for classifying disease and death called the International Classification of Diseases and Death, or ICD coding system. The ICD coding system has evolved a lot over time with about 6 revisions since its inception in 1948. The ICD coding system comes from the World Health Organization, and in the latest revision, ICD-10, there's more than 6,000 codes that can be used to classify diseases and causes of death. As I mentioned, the process of coding the underlying cause of death from the information in Parts 1 and 2 of the death certificate is very rule-based. The CDC's National Center for Health Statistics, or NCHS, developed software that uses a system called SuperMyCar that does automated coding of the literals portion of the death certificate, and SuperMyCar analyzes the information that providers or medical examiners lists in Part 1 and Part 2 of the death certificate, and in many cases automatically determines what the underlying cause of death classification should be according to some rules. The SuperMyCar system can handle the coding of most natural causes and some external causes of death, such as injuries. For those that it can't handle, there's a manual review process that is done by nosologists, and nosologists are expertly trained individuals on the rule-based classification process that I mentioned. The nosologist will do a manual review of death certificates when needed and make a final determination of the underlying cause of death, primarily according to an algorithm, but it nonetheless requires human review to implement in some cases. It's important to note that all of this process does not ensure that the final classification of the underlying cause of death by a computer or a nosologist is the correct one for an individual. If there's poor quality information listed on the death certificate, for example, that can lead to an incorrect classification. But the algorithms used are intended to help arrive at the best guess of the likely cause, given the limited information provided in some instances. To do some quality control on death certificate information, the CDC audits a sample of New York City's and other jurisdictions' manually coded certificates to ensure that there's fidelity to the ICD coding system or rules. And this kind of consistency in ICD ICD code assignment is important, right? So that it's possible to make valid comparisons of death rates by cause over time and across jurisdictions and countries. So let's briefly delve a little further into ICD coding. The ICD coding system is very comprehensive, and it covers practically every disease and diagnosis that can be made. There are 22 chapters in the ICD coding system, and in each chapter it includes a broad disease classification or grouping, usually organized by the organ systems of the human body. So, for example, there are broad sections of neoplasms or malignancies, diseases of the circulatory system, diseases of the musculoskeletal system, injury, and external causes of mortality, just to give you a sense of the broad classifications. And note the codes to the right-hand side of these broad classifications. Each one of these broad classifications has subclassifications and subcodes. So let's go a little bit further into malignant neoplasms. So zooming in on malignant neoplasms or cancers, it includes a range of codes from C00 to C97, and then expanding the different subclassifications of malignant neoplasm codes. You can see that C00 to C14 includes those neoplasms of the lip, oral cavity, and pharynx. ICD code C15 includes neoplasms of the esophagus and so forth. So the codes correspond to different organ systems and diagnoses, and each of these codes has even finer subclassifications. So just drilling down, one level further here into trachea, bronchus, and lung, you can see that that's code range C33 to C34. You can see some of the different subclassifications that, in this case, indicate the specific location or site on the lung where the cancer had occurred. So bringing us back to what we covered early on for a minute, the ICD-10 system is really just a souped up version of what Petty and Grant created in the 1600s and used in their observations on the bills of mortality, where they had some very crude classifications for causes of death. Their list wasn't based on information from healthcare providers, but it is sort of the same idea, trying to understand causes and their distributions. And we've since come a long way in our ability to classify the causes of death, and this in turn allows us to do even more useful statistical and epidemiological analyses that tell us about the major drivers of disease burden in populations. So speaking of that, let's get into some of New York City's mortality statistics that can come from death registration and death certificates, including information on the causes of death on the death certificate. Recall this big picture trend slide for New York City showing the trend in death rate per 1,000 population, all-cause death rate, going all the way back to the early 1800s through 2020 here. Of course, the overall trend has been steadily declining in recent years, reaching an all-time low in 2019. But because of COVID-19, it then spiked in 2020 with a magnitude on par with what we saw during the 1918 flu pandemic. Before we jump into more detail into the 2020 data, I want to show you this table from the 2019 report, which shows the absolute numbers of events. These weren't in the 2020 report. So it shows the absolute number of marriages, births, deaths, and infant deaths per month, and then sums for the entire year here circled in red, just to give you an idea of what these numbers look like for New York City every year. So all told, in 2019, there were 110,442 births, 54,559 deaths, including 464 infant deaths. With about twice as many births and deaths each year, combined with the in and out migration that happens in New York City, you can get a sense of how vital events may contribute to the growth of New York City's population. In this case, this was the situation before COVID-19, and it gives you a sense of the absolute numbers. Then the pandemic hit in 2020, and this slide shows that the number of deaths jumped from about 54,000 in 2019 to about 82,000 in 2020. And most but not all of the increase was due to deaths where the underlying cause was COVID-19. Interestingly, the table shows two different ways that the health department classified COVID-19 deaths. And the top table is what they reported about COVID-19 deaths on their website almost in real time, which was essentially death data linked to surveillance data, case reports of COVID-19 cases. In that situation, a confirmed COVID-19 death was defined as anyone with a positive COVID-19 PCR test from surveillance who died within 60 days of that positive test. This was determined by matching laboratory surveillance data for COVID with vital registration data on the fact and timing of death, not the cause. This process, this approach identified 19,224 confirmed COVID-19 deaths, according to that definition. Probable COVID-19 deaths were those that did not have a positive COVID-19 PCR test, but who had COVID-19 listed on the death certificate. And this identified an additional 5,405 COVID-19 deaths, giving a total of 24,629. And the bottom table is COVID-19 deaths as determined from the underlying cause of death on the death certificate. So when it's listed as COVID-19 or ICD code U07.1, this rule-based system, as you know, a method for coding the underlying cause of death. Using that system, they arrived at 21,242 COVID-19 deaths in 2020. And that is the official number counted in New York City's vital statistics report, based on the information on the death certificate around causes. The two numbers by each approach are close, but they don't match. And that speaks really to the imperfect nature of each method for classifying the underlying cause of death with limited information. And that's one key point I wanted to convey here. The second key point is that we still have many excess deaths in 2020 compared with 2019 that were not attributed directly to COVID-19 by either method. This is about 4,000 to 7,000 excess deaths in 2020, depending on which method you use. While there's no direct mention or link to COVID-19, it's fair to say that the COVID-19 pandemic contributed to the occurrence of these excess deaths, even though there's no mention of it on the death certificate. This is an example of how it's useful and important to look at deaths due to all causes and excess deaths due to all causes to understand the full extent of impact of unprecedented events like the COVID-19 pandemic. These excess deaths could be due, for example, to an inability of people to get medical care during a surge for other conditions that they needed help for. And so we'll be looking at these excess deaths. We're continuing to monitor them since 2020, and they lately they've been returning back to normal, and there have been many fewer excess deaths and sometimes no excess deaths when COVID activity really slows down. Thinking back to the information collected on the death certificate, you may remember that occupation is one of the data elements. In a special section of the 2020 Summary of Vital Statistics report, the DOH summarized the occupational data for all those whose cause of death was COVID-19. And they showed that people working in transportation and healthcare were among the most represented, highlighting the vulnerability of frontline and essential workers in pandemics. Other groups included those working in construction and food services. This slide shows the trends in the age-adjusted all-cause death rate for New York City by sex from 2011 to 2020. The rate declined steadily overall and by sex, with males having consistently higher death rates over the entire period. And while the rates declined nearly 16% during 2011 to 2019, there was a massive increase in 2020 due to the COVID-19 pandemic. And this figure shows a ranking of the leading causes of death over time for all ages in New York City. Since 1970, the top two causes of death were diseases of the heart, followed by malignant neoplasms or cancers, until 2020, when COVID-19 became the second most common cause of death in New York City. In the more distant places of third and below have been infectious diseases, including HIV in the 1990s, and then influenza and pneumonia. Since flu transmission was essentially halted in 2020 because of COVID-19 restrictions, that cause dropped from third to seventh place. And also on the rise between 2010 and 2020 are deaths due to psychoactive substances, which jumped from number 10 to number 6 in just 10 years. And this is, of course, due to the opioid crisis and fentanyl. The other thing I want to highlight here is that lumping all malignant neoplasms or cancers into one category of a cause can be a little bit misleading, since there are in fact many different kinds of cancers and they each can have many different causes and treatments. So in fact, if you were to consider each type of cancer, for example, lung, breast cancer, colon cancer, as its own separate cause of death, you would see a different rank order in the causes of death here. Looking at the top 10 causes of death in 2020 by race ethnicity, you can see that in some groups, COVID-19 was the leading cause of death, including among Puerto Rican and other Hispanic or Latino New Yorkers and Asian Pacific Islanders. This slide shows that in 2011 there were major disparities in the age-adjusted all-cause death rate by neighborhood poverty, which became even wider in 2020. And looking at the distribution of the age-adjusted death rate by New York City neighborhood, you can see that there's major variability. From the lowest to the highest, there's more than a threefold difference in the age-adjusted death rate. So this points to socio-political factors and socioeconomic factors as fundamental causes of health disparities and ultimately disparities in all-cause mortality in New York City. And here's a slide showing the geographic distribution of infant mortality specifically, which uses the number of live births as the denominator. It tends to also track with socioeconomic status and neighborhood poverty. Using information from vital registration, it's possible to calculate the life expectancy at birth. There's a whole section of the Vital Statistics report that's focused on this, but as you can see on the slide, life expectancy at birth has increased year over year in New York City and at faster rates than the US as a whole. A child born in 2019 could have been expected to live to about 83 years of age, but the COVID-19 pandemic greatly decreased life expectancy overall for New York City and for the US by almost 5 years. This is driven mostly by premature deaths or deaths among younger people that would not have otherwise occurred. And the only other recent phenomenon that decreased life expectancy in some groups is the opioid crisis. It didn't affect overall life expectancy, however, the way that COVID-19 has. The expectation is that these will have rebounded substantially once the COVID-19 death rates and excess deaths recede to pre-pandemic levels. So when we started this session, we noted that there were 57 vital registration jurisdictions around the United States, and that allows the compilation of each jurisdiction's data into national vital statistics and national vital statistics reports shown here. The most recent report is for deaths through 2019 at the federal level, so it can only give a sense of what national mortality trends looked like before the COVID-19 pandemic. And so here's a graph from that report. It's showing trends in selected leading causes of death nationally. And there have been some declines in the age-adjusted death rates due to heart disease and cerebrovascular diseases. And there was a slower decline for malignant neoplasms. We can also see some increasing trends, including a rapidly increasing death rate for Alzheimer's disease and rising death rates for Parkinson's disease and hypertension-related deaths. One of the things to note here, you can see the vertical bars that show the ICD coding systems, the International Classification of Disease coding systems that were in place at the time of the death certificates were coded, and where they changed over time, because there are revisions to the ICD coding system. In most instances, these revisions didn't necessarily affect the trends too much, but sometimes, as is the case with nephritis, nephrotic syndrome, and nephrosis, and also Alzheimer's disease, you can see that changes to the coding ICD classification system resulted in some jumps in the trend. And this is presumably because we're better at understanding more about these conditions, and the classification systems are becoming more refined at classifying deaths appropriately. In any case, you can appreciate the long trend in major causes of death in the US from these data, and that's possible because there's some standardization that occurs across all of the 57 jurisdictions that allows you to combine them into one data source for national trends. So the next part of this session is focused on monitoring vital events when vital registration is non-existent or very incomplete. In those situations, it's usually the case that the majority of deaths occur outside the health system and therefore not attended by a health professional and certainly not by someone who can give insights as to what the underlying cause of death might be. So in resource-limited settings, without vital registration or with weak vital registration systems, it's useful to rely on surveys such as demographic and health surveys or DHS surveys. DHS surveys are large-scale, nationally representative household surveys that occur at regular intervals, maybe every 3 to 5 years. The DHS surveys systematically gather information on both demography and health, and some of the broad categories of data that are collected on these surveys are listed here. But highlighting for you some of the areas of reproductive health, maternal health, infant and child health. These are the components of the demographic and health surveys that gather information on mortality. And this part of the session will give you a sense of how that information from these surveys is compiled and analyzed. These are some of the vital events that can be measured through demographic and health surveys or other population representative household surveys. Things include the number of live births, the number of deaths due to all causes and death rates, under 5 mortality, maternal mortality, and adult mortality. And you can also get a sense of some of the methods used to capture the information on vital events and to estimate mortality. This slide's from a study that used several hundred demographic and health surveys from West and Central Africa to compare different methods of estimating the under 5 mortality rate. From the demographic and health surveys of households, women are asked questions like, how many children have ever been born to you? And of those children, how many have died? The surveys also collect information on the ages of children and the years in which deaths have occurred. Of course, recall of the timing of deaths that happened many, many years ago can be challenging, and so it might be more accurate to estimate these kinds of mortalities for more recent years. And the graphs here, they represent the number of children ever born and the ratio of children who died to children ever born, stratified by 2 different categories. On the vertical axis of the whole figure here, you have the number of children ever born, and on the x-axis for the whole figure at the top, you have the age of the mother. And each of the individual panels is the proportion of children by year going backwards from the year of the survey. So on the top left panel, for example, for women 24 to 25 years of age that reported having 3 children ever born, most of the births were in the 6 to 7 years prior to the survey, which makes sense given their younger age. But in the bottom right panel, you can see that some women in this age group with 6 children ever born had births going back 10 or 11 years, which would put them at age 13 to 15 years old. And this slide is from another study that shows trends in the estimates of the under 5 mortality rate in Mexico as estimated by different approaches, including the maternal age and parity method, or MAP, and the mean age of childbearing method, or MAC. Each estimation approach gives the same general trend, which is that there are substantial declines in the under 5 mortality rates over time, and all approaches generally found higher estimates than that of vital registration, which is shown here with the dashed line. And they used these different methods to produce a combined estimate, which is the yellow trend line, which combined the results of different methods using low S regression. And here's a figure from another study that estimated trends in all-cause mortality among adults in Indonesia, Peru, and Tanzania. To get at adult mortality, there are methods used in these household surveys that ask participants not about survival or death among members in their household, but rather they ask respondents to report on their adult siblings who have died. Specifically, how many siblings have they ever had? How many of them have died, and when did they die? Using these kinds of questions on household surveys, it becomes possible to estimate the total number of deaths in the population to come up with estimates of all-cause mortality rates. And here you can see some of the trend estimates derived from these methods, and in this particular paper explores different ways to adjust or correct these estimates of adult mortality in the hopes of making them more accurate. And you can see how the trends vary from one setting to the next. The bottom one shows Tanzania and how there's a very rapidly increasing death rate starting in the 1980s. And while the graph shows all-cause mortality, we know that there were large increases in HIV-related deaths during that time period. So these methods are sensitive enough to detect major changes in the adult mortality rates using the data from the survey. The last examples that showed death rates for children under 5 and adults were for all-cause mortality. They count people who died from any cause. And so it's just tracking the event and the timing of death, but not really the underlying cause. However, we know from the earlier part of this session that while the all-cause mortality rates, especially when stratified by things like sex and age and geography, are very informative and useful, we know it's even more useful to have data on the distributions of the likely causes of death. When aggregated to the population level, it's possible to use that information to gain insights into what the major public health priorities are. It can also help to have cause-specific death rates when attempting to evaluate the impact of different public health initiatives, which might be targeting specific causes of death. So when there are no vital registration systems or weak ones, and deaths are generally not attended by healthcare professionals that can speak to the underlying cause of death, other approaches to get at the major causes of death at the population level are needed. Two common ways to get at cause of death in resource-limited settings are verbal autopsy and disease-specific registries. Verbal autopsies involve talking to family members or the next of kin of deceased persons, and it involves asking them questions to try and get at the circumstances, the signs and symptoms, and the medical history surrounding the death of a family member. The information gained from these interviews gets fed into a computer algorithm that comes up with a best guess at what the likely cause of death was. It's not accurate for pinpointing the cause of death for any one individual, but on average it tends to be correct. So that makes it useful for generating population level estimates of the leading causes of death. The verbal autopsy process maps their findings to the ICD-10 system so that the distribution of the causes of death can be compared in a standard way from one setting to the next and from one time period to the next. Another common method used to gain insights into the major cause of death, though, is through the use of disease registries that track the occurrences of common diseases such as cancers. Since we often have a good understanding of what the mortality and survival rates are for individuals who get certain diseases, we can use disease registries to estimate how many people are dying from those diseases using models and information about the uptake of treatment and treatment efficacy. So these are two major methods to get at information on causes of death in settings where there's not reliable cause of death information coming from healthcare providers or from death registries. So we're going to turn to Haiti now as one last example of the challenges that exist where vital registration is very incomplete. The Global Burden of Disease study systematically scans the literature for information on vital registration in each country, including studies that may have been done to estimate the completeness of vital registration. So in other words, how often when someone dies is the simple fact that the death occurred captured by vital registration? This was the completeness of vital registration. And here are some data points that the Global Burden of Disease study has compiled that show how complete vital registration is. It's really quite low over these years in Haiti, ranging between 20 and 30% of deaths being registered in the 1970s, down to below 20% in subsequent years. And more importantly, perhaps, note in the pink shaded data points that there's really not many data estimates on the completeness, which is a sparse data problem. And very low completeness of vital registration and sparse data on completeness especially in more recent years, contributes greatly to the uncertainty of estimates of any death rates. And it means that you can really only rely, that you can't only rely on vital registration to monitor mortality in Haiti. You have to rely on other sources of information as well. So there are demographic and health surveys conducted in Haiti, and with the most recent one being completed in 2016. And this shows the population pyramid for Haiti at that time. And now you know that with demographic and health surveys that there are survey questions intended to measure mortality using different methods. So on this slide, they've combined information from vital registration with information from the demographic and health survey estimates of mortality, which were derived using the sibling history method to generate estimates of the death rate in any given year. And this process generated a few different trend lines of estimates of the overall death rate, as well as confidence limits or uncertainty intervals around these estimates. And using all of these data combined, the estimate of the number of deaths in Haiti in 2013 was around 82,000. And this slide shows age-specific death rates using the data for Haiti on the slides that I showed you previously, alongside data from the Dominican Republic, estimated using similar methods as compared with that of Cuba and the United States, which are places where vital registration is more complete and reliable. So when you estimate all-cause mortality rates in a given country at the national level, it becomes possible to compare mortality rates from one setting to the next, and in settings that are nearby to each other, as well as settings in other parts of the world. If the Haiti estimates of all-cause mortality are correct, the death rates here are much higher than that of the very nearby Dominican Republic, and much higher than those of Cuba and the US. The Global Burden of Disease Project does in fact report cause-specific mortality data from Haiti, so you might wonder where this cause of death information comes from, given that there's very incomplete death registration happening in Haiti. In fact, there was one verbal autopsy study in Haiti during this time period, and it really isn't enough to generate useful information on causes of death at the country level, especially over time. In this situation, the Global Burden of Disease study looks to nearby countries that are epidemiologically similar, that may have better information on the causes of death. And then they do some modeling exercises and interpolation to come up with a best guess of what the leading causes of death might be and what their trends might be in Haiti, for example. But this is really challenging for a place like Haiti. It's a small island right next to the Dominican Republic. It doesn't really have many other nearby similar neighbors. Indeed, even though it's right next to the DR, those two settings are very different. And I raise these points because I think it's an example of where it's really challenging to get reliable data on the cause of death, especially over time. In this case, there's just not enough data to generate any estimates. So it's really important to keep these limitations in mind when you interpret mortality data, especially from places where death registration may be very incomplete, and in situations where most of the deaths are occurring outside the healthcare system. But if you look at this chart that the Global Burden of Disease study puts together, you get a sense that there's more certainty than I think there really is about what the rank order of the causes of death are in Haiti and how they've changed over time. So just a word of caution that you should always be thinking about the quality of the information going in, especially when you get down to the country level, and in resource-limited settings where vital registration is limited. It really depends on what other kinds of studies were available to go into informing these estimates. So we'll end with a few slides on the Global Burden of Disease study and of just a very high-level overview of how different country-specific data sources are combined to produce estimates of the country-specific burden of disease and ultimately the global burden of disease estimates. This slide shows the mapping processes around the components of the processes for estimating all-cause mortality on the left side of the diagram and those for estimating cause-specific mortality on the right. It's very complicated, and there are even more details in this paper published by Chris Murray and colleagues in The Lancet. But you already have a sense of how all-cause mortality data are generated. And looking at the top left of the diagram here, where there is complete vital registration, it's obviously it's the most preferred source for estimating the all-cause mortality rate. But there are, of course, other sources that we've covered in the session today to get at, for example, all-cause mortality in children under 5 and in adults when vital registration is not reliable. On the right hand of this side of this figure, you can see where the cause-specific information comes from. So either verbal autopsy on the top right or vital registration with ICD coding, as well as some of the other data sources, many of which we've already discussed. So this is all just to say that the process of estimating the all-cause and cause-specific mortality rate in the global burden of disease study is complicated, and it involves combining information from all the potential data sources in the hopes of generating more reliable and accurate estimates. From the same paper by Chris Murray and colleagues, they describe information on the number of data sources used to generate their mortality estimates globally. And this table is showing the number of site years in the database by source type. It shows that between 2010 and 2013, there was a substantial increase in the number of data sources going into the global burden of disease estimates. And something I like about this table is that it shows the types of data sources that they were using. The most common one was vital registration, followed by cancer registries. But then you begin to see some of the other methods that we discussed being used, including the sibling history method and verbal autopsy, but also things we haven't discussed, like police records. So on the far right side of the table, for the global burden of disease estimates for 2013, they also broke out whether the data sources were at the national level versus the state, provincial, or regional level versus the local level. And so there are varied sources of information, and the potential for bias and error can be quite high in some circumstances. So a really important takeaway is that the mortality estimates and the cause of death information that we get from around the world is highly variable and subject to many limitations. And it's important to understand them at some level when it comes to interpreting the data. And on this slide, that same information is mapped geographically, and you can see how the amount of data going into the estimates of death-related outcomes varies substantially by country. In light blue are the countries with the highest number of data sources for mortality estimation and presumably more reliable information. And the darker colors show those areas where information is more sparse. So you can get a sense of how reliable the data are on causes of death and the numbers of deaths, how reliable it might be, and the places where also it might be possible for those less reliable estimates to borrow information from neighboring areas where the data quality might be better. And with this map, the eye tends to focus more closely on sub-Saharan Africa, which we know has many resource-limited countries. And as a result, there's less data available for direct estimation of the number of deaths and the causes of death in many places in the region. But you can also see here that there are many examples in sub-Saharan Africa where there are more data sources available for mortality estimation. Of course, all of this needs to be kept in mind as you look and interpret global cause of death data and the trends of those data over time, as shown here, aggregated across all of the countries of the world to reduce the global burden of disease rankings. So in conclusion, vital registration and the statistics that they generate are really essential tools for public health surveillance and public health practice. Death registration with adequate completeness is often not in place in many resource-limited settings, and in those situations you need alternative data sources and methods for estimating all-cause mortality. Cause of death information is also challenging to obtain accurately, even in resource-rich settings. And in many resource-rich settings, healthcare professionals that attend to the deaths often don't have adequate information or training to complete the death certificate accurately. In many resource-limited settings, most deaths occur outside the healthcare setting, and in these situations, methods such as verbal autopsy can help gather crude information in such a way that it will be useful for at least understanding the distribution of causes of death at the community or population level. I hope this session has given you a deeper understanding of where mortality comes from and where data on the causes of death come from, and also some of the attendant challenges and limitations of those data, and some of the considerations that need to be kept in mind when interpreting and using data on mortality and causes of death as part of public health surveillance. Have a great week.